Hi, my name is Felicia Nunez. I am currently a student at Palm Beach State College, and I will be demonstrating with my friend here, Mary Sue, in a full abdominal assessment. Now, upon starting an assessment, what I would do is come into the patient's room. I will wash my hands, I will introduce myself, and I will let the patient know what I will be doing. Good morning, Mary Sue. My name is Felicia, and I will be performing an abdominal assessment. And I will be washing my hands. I will also be looking for visitors. If the patient does have visitors, I will ask Mary Sue if it's okay that the visitors are around as I ask questions and perform this assessment. If not, I will ask the patient to leave to protect the patient's privacy. Then I will proceed by doing a subjective data first, and I will be asking the patient questions. So, Mary Sue, what brought you to the hospital today? I will also ask the patient about their complaints of why they're at the hospital. I will ask the patient if she's having any abdominal pain. I will ask her to rate her pain 1 to 10, 10 being severe pain, 5 being moderate, 0 being none. I will ask the patient to describe the pain. I will ask the patient to describe the pain, whether it is throbbing, sharp, pressure, dull, aching. If it's constant pain, on and off pain, intermittent pain, I will ask the patient what makes the pain worse and what makes the pain better, and what does the patient currently take for the pain. I will also ask the patient about her personal medical history, if she has any gastroenterology related history, if she has any history of celiac disease, GERD, obstruction, peritonitis, hepatitis, as well as any family history of those related diseases. I will ask the patient if she's been immunized for the hepatitis, and I will also ask the patient if she's been immunized with the varicella, since shingles is a disease that somebody can have if they don't have their varicella shot, and it often shows in the abdominal and lower back pain as a redness or a rash type of thing. So I will ask the patient that. I will also ask the patient about any current medication she's taking. I will ask if she's taking any antacids, any Marilax, just any medications, just to determine if there's any contraindications or any issues with the medications that she's taking. I will also ask the patient if she's having any current weight gain, any weight loss, what's her normal bowel patterns, if she normally has a bowel movement every day or every other day, once a week. I will ask the patient if she's having any issues with nausea, vomiting, diarrhea, constipation, fevers. And I will also ask the patient if she's having any heartburn, any reflux, and also I will ask the patient if she's having any blood in her vomiting or any blood in her stool, as well as the abdominal pain. I will also ask the patient about her typical diet. I will ask, what does her diet consist of, and I will have her describe to me maybe what she ate the day before or what she usually eats on a daily basis for breakfast, lunch, or dinner, as well as snacks. I will also ask the patient about any alcohol use, how often she uses alcohol, and I will also educate her about hepatitis. I will also ask her if she uses any drugs, any substance abuse, and her typical lifestyle. So that will be the subjective data that I will collect through interview with the patient. Then I will proceed with the objective data. So I'll ask my patient to please lay down and expose her abdomen. So I'm going to have Mary Sue lay down, and she will be exposing her abdomen. So what I would start with first is inspection. Inspection is the first step of the objective data of an abdominal assessment. I would inspect the abdomen for skin color, for any redness, any blue areas, any bruising. I would inspect the abdomen for the contour. I would see if the abdomen is flat, symmetric, or if it's asymmetrical and distended. Distended could be a sign of ascites, fluid fill, cirrhosis, or something abnormal. So I will be looking for the contour of the stomach. I will also be watching for any pulsations, any aortic pulsations or paracelsus, which could be an indication for obstruction. So I will be visualizing that, and I will also be looking for any obvious bulging areas that could maybe indicate a tumor or a mass. And then I will be looking at the skin for any veins, any scarring, any stretch marks, also known as striae, and just, just look at the abdomen just to find abnormal findings and normal findings. And with my patient here, everything seems normal. She has a flat, symmetrical stomach. Her abdomen is smooth. Skin color is intact. And everything, there's no pulsations and no peristaltic waves. Then I will proceed with auscultation. With auscultation, we will be listening for normal active bowel sounds. Bowel sounds are gurgling sounds that should be heard one sound every 5 to 15 seconds at each quadrant. So I'm going to divide my patient's stomach into 4 quadrants. Some choose to divide it into 9 quadrants. I will choose to divide it into 4 quadrants. And when I'm listening to each quadrant, I will be listening for one gurgly sound, at least one gurgly sound between 5 to 15 seconds. And that will be a normal active bowel sound. If it takes more than 15 seconds for a gurgling sound to proceed, I would describe that as a hypoactive bowel sound, which could be an indicator for, maybe if the patient hasn't eaten in a while, or a patient is constipated, or it usually happens post-operatively after surgery and with ileus and peritonitis. Now, if the patient is having constant gurgling, constant bowel sounds before the 5 seconds, that could be an indicator of possible diarrhea that the patient is having or early obstruction. So those are what I will be listening to. So I'm going to go ahead and demonstrate that. So we'll be listening to the stethoscope. Of course, we will want to wash our stethoscope before and after each patient. And we will be listening with the diaphragm, which is the largest side of the stethoscope. We're going to start at the right lower quadrant and proceed clockwise. And we will listen for at least a minute each quadrant. In total, there should be about 5 to 30 gurgling sounds with all quadrants per minute. So I'll be listening to each quadrant. And with my patient, I hear normal active sounds. That means I hear at least one gurgly sound between 5 and 15 seconds, which is good. Next, I will be listening for vascular sounds. Vascular sounds are abnormal auscultation sounds that should not be heard, and it includes bruits, which is basically a swishing sound, which is an indicator of turbulent blood flow. You can also hear venous hums, which is a humming sound, which can also be an indicator for decreased blood flow, and also for listening for friction rubs. Friction rubs are a grating, kind of loud sound, which is an indicator for maybe inflammation, tumors, or infarction. So I will be listening for these bruits at 3 areas. I'm going to be listening in the aorta area, which is right above the umbilicus, in the epigastric area. I will listen with the bell of my stethoscope, which is the smaller portion of the stethoscope. So this is the diaphragm and this is the bell. To listen to vascular sounds, I will be listening with the bell of my stethoscope. So I will place the bell right above the umbilicus at the aortic area. And I should not hear any bruits. Then I will also listen in the renal arteries. The renal arteries are at the sides of the umbilicus. And if I hear bruits at the renal arteries, that's an indicator of maybe renal artery obstruction. So I should not hear any bruits at the aorta or at the renal arteries bilaterally. Then I will also listen for bruits at the liver region, which is the right upper quadrant where our liver is. And I will listen with the bell at the right upper quadrant, and I should not hear any bruits. If I hear bruits, that could be an indication of liver cancer or hepatitis. Then I will be listening for venous hums in the iliac arteries, which is just below the umbilicus, bilateral in the right lower quadrant and left lower quadrant. Okay, I will place the bell there at the iliac arteries, and I should not hear any venous hums and no humming. So that's good. And then I will listen for the friction rubs at the liver area, the right upper quadrant, and the splenic area, which is kind of the left upper quadrant, kind of towards the sides below the ribs. And I should not hear any friction rubs, any grating sounds. So that completes auscultation. Next, we will do percussion. Look, the purpose of percussion is to measure the size of the organs of important abdominal organs, and also to determine if the organ or the areas are filled with fluid, air, or a mass. So the way we perform percussion is we take our dominant hand, and then we take our less dominant hand, we place our hand down in each quadrant. So I'm going to start in the right lower quadrant, and we just lightly tap the middle finger at each quadrant. Normally, what we should feel or hear is tympany. Tympany is the indicator that the abdomen is full of air and gas, which it should be. It should not be filled with fluid. The only time you will probably hear dullness is at the right upper quadrant where the liver is. That's when you will have the percussion of dullness, because the liver is filled with fluid. And you will also hear it at the splenic area. And the way you will percuss the liver is you want some anatomical findings you want to look out for is the mid-clavicular line, which is in the middle right here, just at the third intercostal space. The intercostal space is basically the space between the ribs. So at the third intercostal space, you will want to percuss from that area down until you hear it goes from resonance until dullness. Once it starts at dullness, you want to make a mark of it. Then you're going to percuss downwards up at the mid-clavicular line from tympany to dullness. When you hear the dullness, you'll make a mark of that line. Then you're going to take a ruler, you're going to measure it, and you're going to measure the liver. The liver, a normal liver should measure between 6 to 12 centimeters. If it's greater than 12 centimeters, that is a sign of hepatomegaly. Then we're going to also do the same thing for the spleen, which is on the left side. We are going to ask the patient to take a deep breath, and we're going to percuss. And as we percuss in the third to fourth intercostal space down, we should hear dullness at the 9th and 11th intercostal space. So basically right above the last rib, we should hear dullness, and that's normal for the spleen. Then lastly, we're going to check for CVA tenderness, which is something we want to perform last, because if the patient is having kidney pain, we want to make sure that we perform this last so we don't, interrupt the prior, assessments. So I'm going to ask my patient to sit up, and our kidneys are located on our backs, and we're going to look for the costal vertebral angle. Okay, so the costal vertebral angle is where the rib cage meets the spinal cord. And what I will have basically with this is basically a fist percussion. So I'm going to place my hand on the back, and I'm going to do a nice firm fist on the back at each kidney. Okay, when I do this, the patient should not feel any pain. If the patient does feel pain when they do a firm fist percussion, then that could be an indicator for kidney stones or pyelonephritis, which is a kidney infection. So I will do that for both sides of the kidney. Nice firm fist percussion. Then I'm going to ask my patient to lay back down. Next, after percussion, we're going to do palpation. The purpose of palpation is to basically determine if the patient's having any pain or tenderness. So first we're going to start with light palpation. First, I'm going to ask my patient if she's having any pain. If the patient does have pain in any sides of her abdomen, I'm going to palpate that area last, because I do not want to cause the patient pain, and I don't want to aggravate the pain area. So what I'm going to start with is light palpation, which you use the pads of your fingers very lightly, and in a circular motion, you palpate each quadrant. And the patient should not feel any pain or tenderness. Okay, so that's light palpation. Then I'm going to perform deep palpation. With deep palpation, you're going to perform deep. For a larger abdomen, you do bimanual deep palpation, which is 4 to 6 centimeters deep, or you could do it with one hand if the patient has a smaller stomach. So 4 to 6 centimeters deep, I'm going to palpate deeper. And the patient should not have any pain. And my patient doesn't have pain. We're also going to palpate the liver. When we're palpating the liver, we're going to put our right hand on the mid-clavicular line here. And then we're going to put our left hand at the back at the CVA area where we did our first fist percussion. And then we're going to like press upward. It's hard to show you on this teddy bear. Okay. Well, with my hand, my left hand on the CVA area, I'm gonna press inwards, upwards, and then I'm gonna ask the patient to inhale, do a deep inhalation, and palpate in and upwards with my right hand. And I should not be able to palpate the liver. Okay. If the liver is palpable, it could be an indicator of cirrhosis or a liver tumor. I'm also going to do the same thing with the spleen. I'm going to put my right hand, left hand, and I'm going to ask the patient to exhale. Upon exhalations, when I'll do the inward deep palpation. With the liver, you do it during inhalation. With the spleen, you do it during exhalation. So I'm going to palpate together. And if I can feel the spleen, if the spleen is palpable, this could be an indicator for HIV, mononucleosis, cancer, hepatitis. It's abnormal. You should not be able to palpate the liver or the spleen, okay? Next, I'm going to palpate the abdominal aorta, which is with both hands. I'm going to put both hands right at the epigastric area, right at the aorta, and I'm going to palpate together. I should be able to feel the abdominal pulsations at about 2 centimeters. If I feel it greater than 3 centimeters, this could be an indicator of abdominal aortic aneurysm. Okay, then I'm going to palpate the kidney. I'm going to have my patient lay back down, and I'm going to palpate the kidney, and I'm going to have put my left hand or my right hand at the midclavicular line, my left hand at the CVA, and I'm gonna act like I'm like squeezing the patient's kidneys, and I will be ask the patient to exhale and lift, and I'll be lifting the palpation like a downward lift area, and I should not be able to palpate the kidney. If I'm able to palpate the kidney, it could be an indicator of hydronephrosis or a kidney infection or inflammation. Then I'm going to palpate the bladder just to, make sure that there's no palpation. I shouldn't be able to palpate the bladder. If I can palpate the bladder, it could be an indicator of UTI. I'm also going to do palpation with to palpate whether there's ascites. With the ascites, I'm going to choose to do the fluid weight test, where I'm going to ask my patient to put her hand vertically where her umbilicus is, and then I'm going to place both of my hands on each side, and I'm going to while I'm palpating with one hand, I'm going to tap the other hand, the other side of the abdomen. As I'm doing this, if the patient does have ascites, which is ascites of more than 500 cc's of fluid, I will feel the fluid wave on the other side of the abdomen. So as I'm palpating on one side and I tap the other side, the tap side will flow over to the other side, and I will be able to feel the fluid on the side that I'm palpating. Okay, and that would be an indicator for ascites. And that completes our abdominal assessment. We did inspection, we did auscultation, percussion, and palpation. Now, always remember, if you do find anything abnormal during your abdominal assessment, make sure you talk to the patient about following up with diagnostic testings, such as a CT scan, an MRI, maybe an OB stool test, colonoscopy, or EGD. So make sure you always provide qualitative care, and you're very aware of the abnormalities, and always educate your patient and be the best nurse you could be. Thank you.